health research and product development insights to offer better solutions and support to the healthcare design community. Rob grew up moving around the East Coast, Virginia, North Carolina, and Pennsylvania, but settled in Tennessee during high school and never left. He's a sports car aficionado who had to sell his 944 to purchase a more child-friendly car. He's also a graduate of the College of Architecture at the University of Tennessee. And he's been in the healthcare studio at Gresham Smith for 19 years, working with a wide variety of clients across the country. With that, I will turn it over to Annette and Rob.
All right, well, great. Thank you everybody for calling in. We hope we will keep this interesting, and we will definitely have some time at the very end for questions if you have any. Mark will moderate the question session at the end, but let us know if you have a question. As he said, we're gonna do a quick overview of what we think could come out of this current pandemic in preparation for the next one. We don't want to be caught quite as off guard. And while there were a lot of things taken into effect on an emergency basis very quickly, I think we've learned a lot of lessons of what does and does not work from that. So we'll talk through some of the cons, some of the things that we tried and probably spent a lot of money on, and they were less than perfect, and some hopefully inexpensive interdictions that will help in the future. Sorry, I already started this off without being able to flip slides. There we go. 2 learning objectives is really understanding the difference between all the natural disasters and mass casualty events that we have all learned to design around, and a pandemic, which is something that hasn't really been discussed much in the design and isn't really implemented in any kind of building code or healthcare design guideline. And then have some conversation about how facilities can be better prepared based on our lessons learned here. First distinction we want to make is talking about the difference, again, between the different kinds of disasters. Years and years of practice have taught us, we all know how to deal with earthquakes. We know how to deal with hurricanes. There are lots of different interdictions you can have for flood proofing, operations right after a flood. There's emergency generators. But what we've never really talked about is how to deal with a pandemic that can last a year. And is global, rather than affecting a single city or a county, or even worst case, a state. You can see we're at 22 million cases across the world, every country except Antarctica. And there has been no plan and no event like this that the healthcare has really needed to deal with, in the fact that with a small localized disaster, you can borrow supplies and backups. You can get staff and help from adjacent counties, adjacent hospitals. And here, everybody's experiencing the same thing, and that backup is just not available. So what we've learned so far, first thing I'm sure you've all seen in the news dozens and dozens of times now is alternative care sites. This is a picture of one in New York. I believe it could have the capacity for 1,500 patients, give or take, filled up an entire convention center. And I believe, if I remember the numbers right, never held more than 100 patients or something in that range. So a lot of effort, a lot of time, a lot of money went into this, being prepared for it. And come to find out, just because we had those positions available, patients weren't willing to go there. Staff wasn't willing to go and move out of their hospital where they had all their backup departments. They had their backup team. They didn't want to go take care of patients. So they started to become locations for non-COVID patients. But even then, they had a hard time filling some of those up. So I think one of the lessons learned is, absolutely, it's great to be able to have a quick response and be prepared. Being over-prepared is definitely not a bad thing. But we just need to be more careful about making sure we're preparing in a way that will get utilized. The other kind of rapid response is tent cities. Obviously, this is from the military and not necessarily exactly from this pandemic, but you can see you can set up a lot of tent city hospital. The downside to that is they set up really quick. but they don't last long. You know, they're hard to keep clean. They don't get conditioned air very well. Again, it's not a very patient-friendly environment. So if this is part of your preparedness plan, this is not something you want to rely on for a long time. So again, great for a hurricane, not necessarily that great for a disaster that takes a year to recover from. Some of the other lessons we learned with Makeshift solutions, if you've been to a hospital anytime in the last 6 months, you have probably seen signs all over the place that say entrance closed. They shut down, in general, every door except one, and are making everybody come through that one, which definitely increases the odds of being screened appropriately, increases safety, but really can create some pretty bad bottlenecks. And I think moving forward in the future, it's going to be how to address separating those patient populations out before they're in the facility, so that you don't have those bottlenecks and you're not taking potentially well patients and visitors through the emergency department that could have some infection in it. The other thing that we've learned is really we've got to figure out how to lay out hospitals and operate them to where you can have a separate flow for potentially infectious patients and not shut the whole hospital down. That's been the big disruptor to the entire industry, is all the hospitals across the nation have closed everything except the emergency departments for the most part, and emergency procedures. And that's not a very sustainable operation model, as we've all learned, everybody on this call certainly knows. So we've got to figure out how to keep everybody safe, but keep the hospital solvent.
And so one way we looked at doing this, taking a step back and evaluating the lessons learned from these other makeshift solutions, how patient care spaces have been so critical throughout this pandemic, but understanding how ICU rooms, emergency departments, how these facilities have been flooded, just inundated with patients, and the rooms necessarily weren't all able to adequately support the functions that were needed in order to isolate those at most risk. So the big takeaway here was really trying to learn how we can design in a flexibility to isolate those at risk, how infected patients could still be serviced while the rest of the hospital can continue its day-to-day functions. So some of the thinkings, do we want to increase the number of beds? Is that the solution? Is it a scale idea, or is it more about using them in different ways? One idea that's been brought to the table many times has been designing a slightly larger patient room, initially private, that could flex to a semi-private space, which could accommodate then more individuals during that pandemic, as long as neither are infected. But also just a dedicated unit for infectious diseases that could provide much better isolation than just a typical patient room. Maybe it doesn't have to necessarily all day, every day meet every requirement for isolation, but it can flex and support anti-room solutions added on during those pandemic situations. So that's one that's also very much worth exploring, just levels of acuity adaptability within each one of these duplicated rooms. So could it be separated acuities by floor, by zoning for the air and the filtration, ideas around like the safety and security of the fixtures and materials that are utilized within each one of these spaces are also going to be a huge component in terms of durability, longevity, and cleanability. So within the emergency departments themselves, there have been a number of different types of studies in which the patients are tried to, the procedures are streamlined. So the goal is really the throughput of those who are infected. So designing to accommodate different simultaneous emergencies like these infectious diseases could be controlled through separate access points. So just as Rob had mentioned earlier, funneling everybody through one entry point is not only a bottleneck, but it's also a safety hazard. When you could separate the different populations into different flows throughout the department. So those two populations may never necessarily come in contact with each other or cause potential harm. In addition to this, designing for private ED rooms with a door versus just a door versus just a cubicle curtain. That could definitely apply more control in terms of isolation and air pressurization, but also better cleanability and durability long-term. So just a few thinkings on that. And beyond that, just the overall importance of the flow and the throughput for future facilities. We've learned, again, very much about the need for containment, for separation, but also to prevent bottlenecking, but still maintain a safe, secure environment. So one great learning that we've taken away has been all around the virtual waiting room. Maybe these large groups are no longer going to be congregating in a centralized waiting space. Maybe you can phone your arrival in your car and wait there up until you're admitted. There could be a number of different virtual pre-screening or pre-registration methods, automated even. So numbers of different ways in which the time spent within the actual building will be streamlined and minimized. The planning within the spaces, waiting probably won't go away completely, but there will be huge shifts in terms of how spaces are laid out. Maybe they're more compartmentalized so that different populations can be sent to different waiting spaces or holding areas versus one big mixing space. Ideas of partitioning, of separation, of access to sanitation, and of overall flow mapping through the space. Lean processes are still going to be key in terms of planning and preparation. So mapping that all out, understanding who can go where and how the entirety of this time spent can be streamlined from beginning to end. This can all be demonstrated in here. One example just of an emergency department and how it can operate day to day as a typical emergency department would. But the planning for a future state pandemic to allow a secondary entry point, a secondary door, a secondary triage space and throughput so that the two populations of patients never do have to mix. The entirety of the wing that's been opened up for this future state can all be fully isolated and contained. And again, streamline that throughput, the whole flexibility of the emergency department to support the needs of all.
And beyond the need to adjust how we plan and design buildings, there are a lot of infrastructure and supply situations that we need to consider. If you attended the first of the three parts, you heard Gerald talk a lot about mechanical considerations and what may or may not need to change in mechanical units to address the need to isolate patients. You know, I think we've started to see that HEPA filter, at least for a viral infection, is not necessarily required. It's a nice to have, but at least getting to that MERV 16 is going to be necessary. And a lot of what we've talked about, and we're going to continue talking about, applies more to viral infections and viral pandemics than it does bacterial. But that's a threat out there as well, and they both need to be treated differently. And conversations about where the risk is and what the conditions that need to change are for the two different ones, but they certainly need to be considered differently. You would use an airborne isolation room for a bacterial patient, but don't necessarily have to have that tight of an environment for a viral infection because viruses aren't going to live in the air nearly as long. They'll live on a surface, but they don't spread through the air as bad. You know, something I think we'll start to see more and more focus on is really evaluating airflow patterns. It's not necessarily about increasing the air changes, but let's make sure that we're actually changing all the air in a room. Let's evaluate the patterns and make sure we don't have short circuits in the return and supply, and make sure we don't have dead zones in the rooms that just aren't getting those air changes where you've got a chance for something to settle. You know, consider essentially what would be a purge cycle, being able to turn your mechanical units at night when it's not hot outside to full outside air for an hour or two to flush the building. That's something that could be fairly easily implemented without necessarily increasing the size of units and totally redesigning. The other thing that was learned pretty quickly is a respiratory-based disease like COVID is really increased the need for ventilators. And I know we all saw the news early on in the pandemic, what the panic was about how we're going to get all these ventilators built and who we're going to buy them from, and people were 3D printing parts. But what happens with that is you also have a major increase in oxygen and medical air usage. There are reports of 400% increases from over year-to-year basis, from month to month, and only refilling your O2 park is not going to address that because you've just got more patients. It's 400% more patients that need ventilators. So we'll probably have to rethink what an adequate sized lines are for those. Increasing from a 1/2 inch to a 1 inch line, or a 1 1/4 inch to a 2 1/2 would give you that 400% uptick. Your ability to take 400% of the capacity. So those are things that are going to have to be evaluated for cost benefit for sure. And then, beyond mechanical, we do have some architectural details that I think I would consider these a lot of low-hanging fruit. It's things we don't have to do, but now that we've lived through this for 6 months, seem like pretty easy things to maybe make it a little better. And that would be taking those impervious durable materials out of just the isolation rooms. And we need to start doing those everywhere. Sorry, my daughter's trying to get me to help her with homework. So, using solid surface countertops, solid surface sinks, things like that everywhere, not just in those handful of critical rooms. Increasing the use of hands-free devices. We're certainly seeing more and more. I mean, I think everybody uses hands-free paper towel and soap dispensers now. I think we'll see an uptick in use of hands-free sinks, faucets, and wave pads for sure. I think we're probably going to see the end of push plates to open doors here, not too long. And then, another kind of low-hanging fruit is if the need is to really isolate a patient, but you don't need a true isolation room, maybe a consideration is let's just start, do we start evaluating putting closers and gaskets on every patient care space? That's a fairly low-cost item. Closers not required on a patient room door, but maybe it makes it a little bit safer to have a closer on it when you have an event like this. So I think there's definitely needs to be some research done and some testing, but right now, if anything, Annette and I want to just make you guys start asking questions and considering things. Certainly don't have the answers here, or all of the answers, as much as I'd like to say I do. Something else, these were definitely temporary measures, but I think that's something that could easily be stockpiled for facilities. Negative air machines, temporary anterooms, that demountable partition anteroom that you see on the right-hand screen there, could be stored in a stack in a warehouse. And there's no reason a hospital couldn't own a few of those. And if they needed an emergency anteroom, they'd have it right there. It's just another piece of a temporary item that could be stored and used on demand. The next step beyond that is really things that we can guide facilities through, but the facilities have to take on some of this as well. And that is, considering more strategic partnerships. If we know that there might be an oxygen shortage, or you're going to run through your oxygen faster, get that contract in place for emergency oxygen. Make sure you've got your backup plan. That's part of your backup plan, just like you do with in a hurricane zone. You've got that contract for how you're going to get diesel fuel for your generator. Probably treat this the same way. Same with PPE. Obviously we're all still trying to find PPE. I think a lot of facilities have finally gotten caught up, and a lot of facilities are still behind, but maybe that's something that we need to consider having an emergency backup contract for. and maybe it's not just a contract, but maybe the facilities need to reevaluate how much they keep on site. What's their normal monthly use, and we need to increase that and have more room to store PPE. Funny thing that I did not think was going to come out of this, that I've seen several times now, is not just availability of PPE, but now I'm having conversations about how to keep it secure. I've been through on patient unit designs where we start the conversation with, well, we want to have these PPE units all through the department, one for every 4 patient rooms, even if they're not isolation patient rooms. By the end of that conversation, we took them all back out because they were worried about how much PPE would walk away and be stolen. So they need to have it, but we need to think about how they can use it effectively while keeping it safe and secure. The other strategic partner piece there is, systems can do this internally already, but maybe rural hospitals need to have partnerships with larger facilities to transfer infectious patients like this if they don't already, and really starting to consolidate those infectious patients in a single location to take better use of efficient staffing, efficient material supply, et cetera. It's obviously hard to manage when you have 2 COVID patients in every hospital in a state, as opposed to a group regionally located. And then lab, once they finally got testing out there, we had to figure out how to actually process the tests. So that's another issue out there, is figuring out how to have your lab capacity ready. And I'm going to speed up here because I know I've talked too long. Access to care, we put this in here because we just want to briefly mention, some of the issues the hospitals were having is because everybody was coming to the hospital. And I think it's worth a conversation about how to offload some of that. And if you know that you might be infected, but you're still feeling fine, maybe you need to create a crisis portal. And that can be in an outpatient space, MOB, somewhere off campus, and you direct patients that are fearful that they're infected but are not sick at the moment there first, and they can be evaluated. You can run tests, you can counsel if you need to counsel, and then they have the choice to go to the hospital if they need to, and hopefully that relieves a little bit of the pressure on a hospital. Obviously it's a tricky subject. You can't you still have to triage at the hospital, but I think it's worth a conversation about, how do you prevent overflowing the emergency department with people that aren't necessarily sick.
And so the last topic that we wanted to be sure we touched on, which has been a huge learning through this whole pandemic and probably a part of every one of our lives at this point, the Zoom call itself, has been all around how we can leverage technology, how technology has been utilized and implemented thus far through the pandemic, what's been working, what hasn't, and what that's meant for telehealth and telehealth visits. We see a number of virtual work happening within all modes, within all industries, and that is including hospitals. And so we are seeing more virtual work from hospital workers. Those that don't need to be hands-on are working remotely. And so we're seeing not only that, but new opportunities now to explore and understand what telemedicine really can offer. It's created a whole fundamental shift in the way that care is being allocated and distributed, and we're still understanding it and learning about it and implementing it. So they're just within the past 5 months, honestly, it was within the first 2 months of this pandemic, cases, telemedicine appointments, they rose 1,500% for almost across the board. The numbers were just staggering, that anybody who doesn't want to risk the infection of going to a hospital or a healthcare facility can just utilize their own phone, their own technology, and connect and have that consultation. Much of the feedback about that accessibility has been positive, but there's still a lot that we're learning and a lot that is informing how virtual care can move forward and can adapt and grow. And a lot of the feedback that we've received has also been around the locations and the settings in which virtual care can happen, and the need for a more positive experience for the patients. Space is still important even in this virtual shift, in this virtual world. We talk so much about lighting and acoustics and eye connections. Now, so patient and caregiver both need to have that same feeling of connection and engagement with each other and trust. And so understanding how this can help support facilities moving forward and down the road, especially in rural communities or even dense urban centers, access to virtual care can now be much more easily accessible and distributed. And so that can be, it can be applied in a number of traditional healthcare spaces, as well as assisted living spaces or personal home spaces. Even think about retail pharmacies, Walgreens, places like that. On-the-go facilities are all utilizing some new forms of virtual care and consultation or connection. Even your own workplace, many workplaces have a wellness room. It's now a direct line to your private doctor. So thinking about the spatial needs that virtual care is now going to be offering in a more mainstream way is also now a true reality. So worth talking about. And just a quick quote from our CEO, what we really truly believe, within every crisis, there lies an opportunity. And so that's what we're trying to take. Rob and I are looking at the silver lining of all of these learnings, of everything that we've gone through, and trying to figure out now what ideas there are to try to help support a better world.
So in summary, since it is 3:01, we just kind of wanted to put a couple of high points up here on the screen, and honestly just leave this up for you guys to hopefully foster some questions. So we'll open it up if anybody has anything they'd like to mention or ask.
Gee, I'll break the ice so that we don't have any questions yet, but what would you all say the primary watchword is? If you were to take one word away from this, what would that be?
Oh, it's flexibility.
Flexibility.
Yep.
Is that
That's
a trick question?
And I think, it's going to take, we're going to have to study this for a while longer. We've learned a lot, but there's a lot more to figure out on how to be prepared for the next one.
Yeah, I think that I've talked to a lot of our clients that, changed airflows and repurposed patient rooms, took maybe a med-surg unit and put higher acuity patients in there. Mm-hmm. I did hear the Vanderbilt Symposium several weeks ago. One of the panelists was from New York and Northwell Health, and he talked about the oxygen shortage and said that was a real issue for them because these patients, even the ones that weren't on ventilators, were on high flow oxygen, right. And so many of them that it was an issue. And I think that's that's a big takeaway. That's something that really didn't come to mind initially, but as soon as he said it, it was like, oh yeah, that makes all the sense in the world.
Yeah, and it's really, I think what we need to make sure we don't do is think about how to address the next COVID. We've got to think more outside the box than that, because there's a lot of things a pandemic can be, and the next one might not even be respiratory. So I think one of the big fallacies would be make all these changes and really focus on how to address a respiratory disease and have something different.
Agree.
This is David Stewart. I have a quick question. Have you guys heard, I know the FGI is kind of out for comments right now for the new version. Have you heard any talk about some of these things being incorporated into the FGI?
So I might ask Mark to step in here a little bit, but I in reviewing some of the Vanderbilt Symposium, Dave, I don't know if you were able to go to that, but there was a presentation, I believe, on the FGI, and they are looking at it, looking at not just guidelines on how to address it, but guidelines on, you know, what can we, what's going to be okay to do, even though it's not quite within the guidelines in the future. You know, how do we take those real emergency steps and not have to shoot from the hip and figure it out.
And I think he had 3 categories. He had an emergency change, a temporary change, and then a permanent change. And the emergency was like, you know, a week that you're going to operate this way. And I don't remember, was it up to 3 months for temporary, something like that. But there were 3 categories, and FGI is going to issue guidelines on how to handle each of those circumstances.
Now, I don't think that's actually in the draft right now, is it, Mark? Because I've looked through the draft a little bit and it's not there.
No, it's going to be a separate, I think it's going to be a separate document even.
Okay.
Great, thanks.
Yep.
Any other questions? Don't see anything in the chat.
Well, I just want to thank all of you for being here today. I hope you took something away from this, and I especially want to thank our presenters, Annette and Rob, for their time in preparing for it and delivering it. With that, I thank you and look forward to our next AAH session, and hope you all can attend again. Have a great day.
Yep, thank you all for coming.
Thanks, everyone.
Thank you.
Have a great day.
Thanks.